In part 8, we're going to have a look at the assessment of malignancy in odontogenic lesions. Malignant odontogenic tumours are extremely rare. Even in a large maxillofacial pathology practice, we do not see them very often at all. And in fact, when we had a look at our Sheffield experience of these lesions, we found, particularly if you see the section here from the table, which is entitled local, just how rare they are through a routine practice. The vast majority of experience that we have is from referral or consult cases. So what are the main issues? So when should I be concerned that a ameloblastoma has transformed, and what might help me to make that decision? Or what happens if I get a malignancy in the jaws? What will help me to work out whether it is odontogenic in origin or not? So what about ameloblastomas progressing to malignancy? There are a number of cohort studies, the largest of these are from China, indicating a malignant transformation rate of about 1.7% in a large cohort. Older patients, more in the maxilla, and larger lesions were associated with increased risk. So this brings us to case number 9, which is a 55-year-old male patient who had an expanding lesion of the left maxillary tuberosity over a 2-year period, but was asymptomatic other than that. So here we have a lesion, and you can see again it's useful to have a panoramic radiograph so you can compare the two sides. Look at the tuberosity, that's the area behind the last standing tooth in the maxilla on each side. On the left-hand side, you can see it looks as if there is something missing. And that's also borne out in the sectional imaging, as you can see here. The histology from the incisional biopsy, as you can see here, looks odontogenic because there is an appearance of islands with the peripheral cells, reversal of polarity. They look a bit like ameloblasts. Maxillary lesions, we tend to give a little more leeway in terms of how crowded they are and so on than we would necessarily do for mandibular lesions. And this, an incisional biopsy, was indicated as being an ameloblastoma. And so the lesion was excised. And this is one of the cross sections of that maxillary excision. Largely, the histology bore out what we saw in the incisional biopsy, but there was increasing crowding in areas, and cytological atypia were present. But again, this was signed out as consistent with an ameloblastoma. Then the referring pathologist sent to me a later clinical incident from the patient where the patient had developed lymphadenopathy, had a core biopsy, and this is the appearance from the core biopsy. As you can see, there is epithelium which looks very similar to that which we see in the ameloblastoma, and the panel on the right-hand side is the Chi-67, which is proliferation fraction, clearly quite high for an ameloblastoma, and obviously being metastasized, having metastasized, we're thinking that this has actually been malignant. And in fact, when you actually return to the excision specimen, and there were some certain fragments which had been detached from the main specimen, and these were then examined in more detail, and the extent of cytological atypia, mitotic rate, and so on was evident. And then when you have a look at the proliferation rate by Chi-67, you can see that it is much higher than the 5% we very often see in ameloblastomas. In fact, it's probably about 20 to 25% of cells. So the final diagnosis, by a sort of roundabout way, was that this was an ameloblastic carcinoma with lymph node metastasis. This brings us to a point in which the assessment of malignancy in ameloblastoma, particularly in the maxilla, is very challenging. Cytological atypia, which is normally seen in malignancy, these are things, of course, we're looking for: abnormal mitoses, necrosis, areas of dedifferentiation. Obviously, metastasis itself gives you a certain extent of an answer, although there are times when that's not necessarily helpful, but we don't really have the opportunity to go into that today. And then there are the confounders. The site, I said, the maxilla can be difficult, and the histological differences in maxillary ameloblastomas can make that challenging if there's concurrent inflammation. And the concept which some people have raised about, in situ change, similar to that we might see in a pleomorphic adenoma, I happen not to think that I don't think that's a useful concept in odontogenic lesions. So here's a crowding and pleomorphism we might see in a lesion. This has got less obvious odontogenic features to it. The stellate reticulum-like areas have disappeared. Just remember, though, not to get carried away with looking at pleomorphism, because there are some tumours, for example, the CEOT, which is benign, which can have striking pleomorphism, as you can see in the image here, but is benign. Budding of the basal compartment may well be useful. And perhaps the most single useful thing, which is good evidence for, is the use of Ki-67 in the assessment of malignancy. And ameloblastic carcinomas do have a higher proportion of cells which are present, which express Ki-67 are proliferating cells. Other cytokeratins, stem cell markers, and other classic oncogenes and tumour suppressor genes have been looked at in this context, but none have really proven to be particularly useful. And Ki-67, perhaps at a cutoff point, a really pragmatic cutoff point of about 20% of cells, may well be a useful, helpful indicator. The cytokeratin profile sometimes change. Here's a case that we of a referred case where you see the cells, cytokeratin 19, ameloblastoma, progressing to ameloblastic carcinoma in the top half of these, and you can see the difference in the proliferation fraction in this case. What about the definitive diagnosis of odontogenic carcinoma itself? Well, a combination of features are going to have to be assessed in that circumstance. You have to bear in mind the site, the morphology. We're looking, is there any indication at all that there's a hint of odontogenic differentiation? Odontogenic epithelium expresses cytokeratin 7, 13, 14, and 19, as do many epithelia, and that varies by stage of dental development, and none of these is sensitive or specific alone to be useful. And it is at times important just to be prepared to say that it's not possible to be certain at times, and the imaging and, for example, PET scanning for looking for other sites of a potential origin may well be useful in certain cases. So here is an example of a large destructive lesion on the right-hand side of the mandible. This is an odontogenic malignancy, very expansile, and the patient effectively has a pathological fracture. Here's a less spectacular example, relatively well-defined lesion, but still quite destructive. It is superior to the inferior dental canal. It's definitely within the tooth-bearing area of the jaws. One feature of ameloblastic carcinoma is that it is very histologically variable. And you can see the growth pattern, both of the epithelium in terms of follicular, plexiform, basal, trabecular, and so on. Many of them have undifferentiated areas, and there are also some areas which have some which will have stellate reticulum, many won't. Many are more closely packed and undifferentiated areas in the center of the nest. And so here's some examples from our own cases. Left-hand side with a hint of a stellate reticulum, central, very solid, and then almost a sort of biphasic appearance in the lesion on the right-hand side. And these are all seen fairly commonly in these lesions when we get them on consult cases. Here's an example of a gross image and a low-power histological image of a malignant odontogenic tumour. It's a case which has come to me from Dr. Bill Barrett, which I'm very grateful. And again, you can see here in this case, it's got these predominant strands of epithelium in a very fibrous background, but histologically, the pleomorphism and extent of that and the mitotic rate indicated that this was malignant, and there are abnormal mitoses, as you can see. So overall, we would tend to use cytokeratin 14, 19, perhaps CD56 and calretinin related to some of the expressions in ameloblastoma. But as I indicated, I think in many instances, Ki-67 is perhaps the most useful of the immunohistochemical markers. Other odontogenic malignancies include primary intraosseous carcinoma, NOS, and this is also assumed to arise from odontogenic epithelium. Some arise in cysts, be they keratocysts or other cysts, and these are relatively rare lesions. And here's an example of a primary intraosseous carcinoma where we've got the radiograph and the biopsy, and you can see the cytokeratin expression extensive, but the pleomorphism is very evident in the H&E, and most commonly seen in the posterior mandible. As part of making the diagnosis, of course, it's very important to rule out an origin from a surface or a metastasis from elsewhere. Here is another example, much less obvious, more subtle. The lesion is a rather diffuse radiolucency associated with the crown of the unerupted lower left third molar. In fact, this was a primary intraosseous squamous carcinoma. It was the one on the left-hand side here, the well-differentiated one. We have seen lesions which are, some are well-differentiated, moderately differentiated, and poorly differentiated, so they're graded in the same way as surface lesions are. And we also see variations in the stroma. Some have a very active myofibroblastic stroma, whereas others, it is not that. So some of them arise in cysts. This is a recent case associated with, this is assumed to be an inflammatory cyst, and there's some indications that there may well have been a pre-existing odontogenic cyst, but it was at the boundary, this was very infiltrative into the surrounding bone and had areas of necrosis and significant cytological atypia. The molecular pathology of these lesions is complex and is still to be worked out. There are some small studies which have shown relation to ameloblastoma in terms of BRAF V600E mutation, but no consistent areas of gain and loss have been identified, and so work is ongoing, including work that we are doing in Sheffield. Odontogenic sarcomas are even rarer. Ameloblastic fibrosarcoma, which is the common of the two, there are a significant number in the literature, and these tend to be mostly in the mandible, and I've only actually ever seen one of these for diagnosis, and those which contain hard tissues are even rarer. So here's an example of a case that I was sent. Again, a lesion, which you can see there is odontogenic epithelium in the H&E, but there is an expansion of the cellularity of the area in between a lot of these islands. Very cellular, very dense. The epithelium component looks okay, but there is pleomorphism and a very high mitotic rate in the background mesenchymal component in this ameloblastic fibrosarcoma. So as far as take-home points for this, malignant odontogenic tumours are very rare, and practically Ki-67 can be useful in ameloblastomas when there is concern of malignant transformation. Now, I have a number of people to thank as I come to the end of this presentation. Again, there are many people who have helped me in my love of all things odontogenic, and I'm very grateful to these. As you can see, a number of them may be familiar to you at the bottom here. I'd like to thank you very much for your attention.